multilinear probe that would be using for kidney and bladder, and this is the transrectal probe, and this is the just one, this is monopolar probe, and this is the biopsy cavity. Now the first thing that I would be showing is the upper tract, right kidney, left kidney, and then the bladder. So it's an elderly male with a BS of around 9, and he has been catheterized because of retention. So probably you will not be seeing the bladder in much of detail because it is collapsed, but I will definitely show you the kidneys how it looks. My probe is translating into the cranial end. So if I reverse the probe, can you see I am moving at the cranial end of the probe, but there is a movement at the caudal end of the probe. That my complete anatomy changes. So it should always be corresponding. Now that means my probe is correctly oriented. Now the first thing that I have to do is this is the rib cage, this is the kidney. So the kidney would be half in the rib cage and half below the rib cage, and it is 30-degree posterior. So my first probe, so the thing is I hold my probe like this, okay, and I would place my probe 30 degrees tilted. So that is how I will see the kidney. So the first thing that you see is your liver. So the first thing that you see is your liver, and then you see this kidney picture. So this is the kidney. Here, can you make out? Yeah. So now the first thing that you have to see is, so you see the cortex and the medulla. The medulla is always hyperechoic because it has fat into it. Now the cortex has to be hypoechoic, the medulla has to be hyperechoic, and that is how you may say that the CM differentiation maintained in CKD patient. Your cortex also becomes hyperechoic, and that is how you say there is loss of CM differentiation. That is what your report says. And how do you compare it with? This is your liver. Okay. So if you see with that liver, you have to compare, and now with this liver, it is either isoechoic or it is hypoechoic. And you see the pelvic collection system is not dilated. It is giving you so details. Can you see the pulsation of the vessels in that kidney? So it gives a very good detailing about the kidney. Now we will shift to the left side. Now we will go to the left side. As I said, the left side is slightly challenging. If that does not happen, then what you have to do is you have to ask the patient to tilt it towards your side. Again, you have to go. So this is the screen which is seen. I still cannot see the kidney. So what I will do is discover kidney. Especially this is required when the patient is still. Okay. So you have to take efforts. Now this is what you can see is the kidney. Okay. So that kidney has a lot of cyst into it. Okay. So this is the spleen. This is the spleen that you can see, and this is the kidney that you can see. Obviously, the resolution of upper tract that you would see from other machine is slightly different with this machine because it has a lot of frequency to it. But this is something that I would like to tell to it. So this is the upper tract that we saw, and now coming on to the bladder. Now you first see the bladder in transverse section. Can you appreciate the prostate and the bladder and the? So this is the prostate. Okay, this is the prostate. This is the bulb that you can see, and this is the bladder. Now, if I were to see it in transverse section, okay, if I were to see that in transverse section, so can you appreciate this? Okay, so this is the bladder. Okay, so this is the bladder. This is the bladder. This is the balloon, and this is the prostate. So this is the prostate. You see, there is some intraprostatic projection, intravesical projection of the prostate, because of which the balloon is up. So this is your prostate, this is your bladder, and this is your balloon. Okay. So now we will shift to our transrectal ultrasound.
So I think it is very clear that what we have seen right now is, so one thing we have seen the system was compact, and one side we have seen some echoic shadow. So anything echogenicity is xenostat. If on ultrasound you can see those xenostat echogenicity, this means there is no hydronephrosis. The first thing, when a hydronephrosis develops in ultrasound, then echoic shadow will be replaced by anechoic area, and that is the thing when hydronephrosis develops here. In this case, we have seen there was no anechoic area, since the system was compact and there was no hydronephrosis. So ultrasound will easily assess whether you have hydronephrosis or not, whether the mild, moderate, severe, generally depends upon your kind of whole calcium secretion. So I think now we will basically be discussing now on transrectal anatomy with a 29 megahertz ExactVu. let me just already Dr. Abhijit have told you about the difference. Now this machine, if you focus on that, so probably this is an you can see the armamentarium there, Tahir. Yeah, you need to be loud, Tahir, from that side. We can listen you very quietly.
Yes, sir, we can clearly see, sir.
Now it is good. Now the probe which Dr. Abhijit is using, it will be a 29 megahertz probe, which is a transrectal probe. It is a side-firing probe, and as compared to the other ultrasounds which have ideally 9 or 10 megahertz. So let us see how this increased frequency will make a difference in imaging of a prostate cell section. Rest, if you go with the probe of rest, all the features are equally there in both the armamentarium and other machines and these high frequency machines, and they are equally good. So I think the difference is 29 megahertz in rectal probe, which now Dr. Abhijit will transfer.
दादाजी एक दवा डालते हैं और चेकिंग करेंगे.
So always tell the patient as to what you are doing. धीमी सांस लीजिए, and then you inject a lot of complete lignocaine into your transrectal approach. Now once this is done, this is the probe that you see. So first what you have to do is you have to put some lignocaine or an ultrasound jelly to the point of catheter. This is the biopsy attachment which is provided by the company, and this is a side firing. You have to understand, if it is side firing, that means this is the probe, this is the prostate. So the probe is looking at the prostate and it takes the biopsy on the side of the prostate. But if you have to do an end firing, then you see that other probe will have an array over here. So this is the prostate. You look at the apex, and then with that you get an end firing of biopsy. So this is, I am going to show only a side firing biopsy. Now we insert the probe. दादाजी ढीला रखिए. Okay. Okay. So now, okay. You see this prostate. Now the first thing that I would look is the urethra. Can you see this catheter?
Yes, sir.
So instead of urethra, this is the catheter which you see. Now this is what I am telling. Can you? So the cauliflower that you see, can you appreciate this region as a cauliflower?
Yes, sir. We can clearly.
So you can see the rest of the prostate, and you can definitely see this lesion. Okay, you can definitely see this lesion. So this is primus for a cauliflower lesion. Okay, and that is how you understand. So this is the extreme right end of my prostate. Now I am scanning clockwise. Okay, so this is clockwise to orient you. This is the bladder base. This is the bird beak side. This is seminal vesicle, and this is the prostate. Okay, now you can definitely see this lesion. Okay, now I am going clockwise. Now in midline, okay, so I see this catheter, and now once I see the catheter, that means I cross the midline. I am going toward the left side of the prostate, and now this prostate finishes on the left side. Okay, so now we will do what we will do is you will take 3 biopsies, parallel on right side, 3 biopsies laterally on right side, left parallel 3 biopsies, and so we do a 24 biopsy. But especially in this case, if you see, see this lesion, it is so well seen that you can still go away with proper 24 biopsies. Now, as a procedure, what we do is we instill anesthesia, local anesthesia. So this is the place between the prostate and the seminal vesicle. This is where your neurovascular bundle would be. Now, there are 2 types of guide. As you can see, this is the first guide, which is for anesthesia, and this is for anesthesia. And you see, this is the area where I have to target. Then you see, this is the area where I will be targeting. Now, this is an IP needles that I would be inserting through it, and then I would instill. So this is a 16 gauge needle, and that is how you see from the attachment I am going over there, and then you can see the track. Okay, now you can see the track. Okay, it's rightly relating from its track. So this is where I have got. Okay, now can somebody come and help you? You just remove this. This. and you still fasting. Sorry, the liquid. Yeah. Half of it here. So this is the right side. You have to inject it on both sides. Fine. Now we remove this. Okay. Now this was on the right side. Now I will go on the left side. So on the left side, again at the same junction. Now this will probably decrease the mucosal pH. Okay, but it will still have the sphincter pH. So this is that one here. Now remove this and inject it. Can you see the fluid over there? There's the fluid which is getting injected. Now this finishes the local anesthesia. Now we would keep our target. So can you just hold this? So now we have this done from bar. Okay. So how do you do it? This is 18 gauge needle. Okay. So this is 22 centimeter. The smaller size that you have is for kidney. So what you do is you do like this. Okay. And with this you fire it. Okay. And then once you have done fire, you just press this and you would have a pore over here. Can you see this? It's around a 22 mm pore, and then you give it to the this fluid that is present. Okay. Now this is how we would biopsy it. Okay. Now as we have decided, we would be biopsying it. So again, let's get oriented to what we are doing. Now this is the lesion. Can you see the lesion? Yes, sir. Okay. Now let's see where the catheter is, so that we understand where the line is. Okay. So this is the catheter. Okay. Now what we do is, so this is apex, this is mid gland, and this is base. Can you appreciate?
Yes, sir, we can.
This is the base, this is the mid gland, and this is the apex. Okay. So and we are just near the catheter. So if you see, this is right apical paraurethral biopsy. So I go here. Always tell the patient, यदि आपको एक आवाज आएगा, आपको डरना नहीं है. You see, can you see this mark?
Yes.
And for the residents, why is it hyperechoic? Can anybody tell it? Why this tract is hyperechoic? So this tract is hyperechoic because there is a small amount of bleeding that happens along this tract. That is why this is always a hyperechoic. Now again I insert this needle to my guide. Somebody can just help me. Okay, so this was the apex that we took. Now we go mid gland. So you come till the prostate. Can you see? I have come till the prostate and then I fire. That is how you get this. Now I want to come at the base. So this is the base. Again, I traverse rectum. This space between the rectum and the prostate. Come over here, and then I see I am in the substance of the prostate, and now I have taken the lines. Now again, mid gland, right lateral. Lateral, and then the base. Lateral, base, right side.
While we change the probe, so one thing we understood right now. So if you just focus on this, can you see this?
Yes, sir, we can see that.
You can see it now.
Yes, sir, we can appreciate.
So can you see the starry sky?
So your voice is low.
Can you see the starry sky?
Yes, sir.
Thymus 4.
Yes, sir.
Focus on
Yes,
this.
we can see.
Yeah. So this is the image in this case. You can see the thymus 4. You can just have a brief idea. You know all pilots 1, 2, 3, 4, 5. So primus 3 is equivocal. Primus 1, 2 doesn't require a biopsy. Primus 4 and 5 require a biopsy. This is a staging based on this high frequency ultrasound in literature. We got it that when we study the literature, this is I think and it was probably proposed by Dr. Lawrence Scotts, and he has done a lot of cases and he has proposed this grading. And in this case, this is a sterilized scene, and probably we are dealing with a primus 4, and there is a hypoequivocal lesion also which was shown by Dr. Dichi. So probably the primus 4 and 5 lesions in this patient, and we are doing a biopsy. So understand this ultrasound, but this is only the 29 megahertz classification, not the other ultrasound in literature. So we can over to Dr. Dichi.
The track that is hyperechoic, I come over here, and that is how this is my right base ladder. Okay. Now I still come over here since I know that the disease on the right side. I will look at this mass. Okay. So this is the mass that I would target. Now this is I am taking suppose a targeted biopsy. So this is what I am interested in. You see, it's a complete mass which is seen. So I will come over here, definitely come over here, slightly here, and then this is the mass for which I will go. So if I will label, this is the targeted biopsy. Okay. Now you see this urethra. You see the urethra over here. Okay. Can you appreciate this catheter? Yes. Now I go on the other side. So this is base, apex, left parallel. Okay. I traverse to the prostate from here and fire. Now I go slightly up. Now this is midline, left parallel. I hope you are understanding the schema. Yes, sir. I would again go into the substance of the prostate and then fire it. So this is the beauty of this machine. It is showing you the complete architecture of that prostate, and also, so you see this is the vertex that I was saying. Can you appreciate a peak of that bird which is present over there? Yes, sir. Left side also. Okay. Now again, this is the base, left para urethra. Okay. Now again I come to the apex. This is the complete left side. After this, there is no prostate. So this is left apex lateral. Understood? Yes. And this is the sphincter. This is the sphincter area. This is the apex of the prostate. So this is through this, and this is the apex left lateral. This is midline left lateral. And then this is the base left lateral. So the only thing in this machine, you cannot have two views, but probably the high resolution of this machine negates that problem. Now we are done with that 12-bore biopsies. We have taken from that the mass also, and I would just scan the prostate to show this needle marks that I had shown. So you see all these 3 needle marks. Okay. So as I go anti-clockwise, you would see all the needle marks that I have taken. Okay. Can you appreciate this biopsy marks? Yes, sir, we can clearly see.
These tracks which are seen, we got the BGP showing. Imaging which can show you the track nicely, you can reframe your biopsy site again so that you don't take a biopsy from again from one point. Right? You can change your location. Even follow-up it can help you.
The last biopsy that you take is again a targeted biopsy because I know this is a highly suspicious lesion. And can you see? It has gone through the lesion, half of the lesion is above and half of the lesion is below. Yes. So this core should definitely have the malignancy, and probably what over time will happen is that they will stop doing systematic biopsy, see the lesion, have a complete 100% core positive of the lesion. So two things you achieve. You prove that the patient has clear prostate. By local anatomy, probably I understood that there is no extra prostatic extension. Now there are two things that you have to see. This is the prostate decidal, and if you see, then this would be rectum, this is the prostate. Now this is white line that you see. Can you see this white line over here? Yes, sir. Now what is this? This is the fat present between the prostate and the rectum. Now, if there is an extra prostatic extension and if there is involvement of the rectum, you would see this breach of white gland and you have a lesion over here. Then that means then probably the fat place between your rectum and the prostate is lost, and then you should be taking extra steps either to operate or to give some neoadjuvant hormone therapy and think in that ways. So this transrectal ultrasound, especially with this high resolution, gives you all the knowledge that you want to prove the disease and to locally state the disease. I hope this was quite useful and understanding. So this is as I come here, the only thing that I will tell is sphincter tight करने के लिए बोलना. You see over here, when you see this area, so once you pose this patient for IRP, you should be asking this patient to do Kegel exercise. Now you ask that patient to yeah, can you see?
Yes.
Can you see the sphincter got? So that is how you can understand whether the patient is doing proper Kegels or not. Okay, so you ask this patient and you ask them that the thing that you did now is exactly what you have to do in future as an Kegel exercise. So from this ultrasound you can understand whether he's contracted the proper muscle.
So I think what you can understand, Dr. Abhijit, if what this ultrasound probably is helping us in more of a not only diagnostic but also local staging with information what we got from MR.
Yes.
So if we do it carefully and if we learn it over time, we can get information. All those information we can have, which we get for local staging.
Yes, sir.
As well as for a biofeedback. When we plan a patient for IRP, plan rehabilitation is an important part, and usually you do this is also a method of a biofeedback to know whether the patient have learned Kegels or PFMT exercise properly or not.
Yes, right. So probably that in near future, if you don't have an access to an MR, you have a complete knowledge that you want from diagnosis, from the surgical point of view and the follow-up point of view, everything that you want. And the last thing I want to tell is, suppose you have done a TUR of this patient and the patient comes back with the poor flow, then if you do a transrectal ultrasound, you can actually see the defect in that prostatic fossa and you still see that there is something which is jutting at the bladder base or at the apex. There is some nodule which is present. That means that is causing poor flow in this patient and might be you will have to go and resect the fossa again. So that is an important one.
One more thing I want to add, when you go through a literature, what I personally found in literature is that whatever biopsy we have done now, we can all see the tracks there. But if you follow this patient in due course of time, these tracks are still visible because of this high frequency. You can even follow also these tracks are visible very nicely, which is not usually visible with the low frequency. And they can also help in discriminating. I think this is a more precision point of view that we are seeing. And if we see properly, probably we are staging it better, diagnosing it better, and it may help us.
It helps the patient. And the last point you made is, you see the patient was comfortable, allowed the proper biopsy of 12 to 13 course just because he was given a prostatic block. So this is a very simple thing that you could have done. And with under prostate blocks, even mild sedation you can do an office transrectal biopsy.
Thank you everyone. We will have a... Yes?
Dr. Gupta here in the audience.
Sir, please, good morning, sir.
I have heard your comments, there is discussion also. So the question is, what you are saying is that the places where MRI is not available, this ultrasound can be used.
Yes, sir.
But what about the centers where MRI is already available? And in our clinical practice, we are asking for MRI before a biopsy. That is the standard practice nowadays.
Yes, sir.
So you have to clarify it. So it is going to replace MRI or no? It is only when MRI is not available.
So I think, sir, as you rightly said, in the current scenario, as per guidelines, we have to do a staging protocol where NP-MRI is the standard of care. No doubt about it, it's the standard of care as of now. And we usually do NP-MRI before we plan a patient for biopsy. Now it is very acceptable. I think the centers where MRI is not available, primarily I think it's not a limitation primarily for India right now, because MRI availability in India is not a concern. Easily available and at low cost, I should say. The limitation is high cost. The centers where it is not available, yes, there definitely an end user or an observer by this system can stage the patient better where MRI images or MRI information is not available. But if you have an MR prior to the biopsy, that MR and cognitive fusion will definitely help you, and definitely the gold standard right now. It cannot replace their system. as of now, but definitely it will add to it, sir.
May I add a point for resident? So for residents, the take-home message is that if you ask an exam what is the local imaging that would do, still the recommendation guidelines it is FTMRI. It is not still in the guidelines. So you have to say from exam point of view, the answer is FTMRI. But what benefit that this machine is giving you is, as you see, the lesion was so well defined. So it gives you a targeted biopsy and a maximum yield from the minimum number of 4 biopsies. That is what is it as of now the benefit of this machine. So to in nutshell for all the residents.
So I think Gupta sir, we can have your insight as you are there. So we already had quite years back targeted systemic, target plus systemic, and then there was a good amount of evidence that when we do targeted alone, there is a high probability that still we can miss, the result. So still doing only targeted biopsy is not a standard of care as of now, as per our understanding, sir. Gupta sir, your insight over it.
No, I agree with you. I am doing MRI transfusion biopsy since 2012. We have published our paper from Vedanta also. Our first 200 cases we have analyzed, and Dr. Suminder Bansal was my resident at that time. He was doing DNP. So I have also given in my published paper the guidelines for the fusion biopsy. I don't say everybody should have a fusion biopsy. There are certain guidelines. If you want 5 points, I can tell you there. Second thing is, this machine is fine. The resolution is better. I agree. But highly controlled trial has been done between the standard machine. What we are, I trust guided biopsy. I don't need fusion and all that. That's why instead we use a standard machine now. Much is the difference between the two? Because the cost factor will be coming here now. Because in every department there is a machine which you are using for multi-purpose and top network. So any trial has been done to show that this machine is superior, or we have to go only for this machine, not for the standard machine.
So I think, sir,
Anybody from company side also can answer.
Yeah, I think, sir, if we can see, there is a trial, which is the optimal randomized trial, which was published, and I think I should say the literature is still not mature enough to comment upon anything. I think this is a raise and training session, so we should just message what we all need to convey. Gupta sir is there, and we are all here. The first thing is that let us learn about all the armamentarium which are available and which are about to come and which are in place. So the difference and how it is seen in both the systems is our logic today. And presently, the standard of care, I again say, we need to get a MR and get a planar biopsy. Whatever biopsy system we have, whatever machine we have. But yes, I think in due course of time, these armamentariums are coming. They have one limitation or one strength over each other. We need to learn, sir, today. That is the only point today we can give to the residents. And there are some scoring systems which has been proposed based on these systems. But I think again the literature is not mature enough to comment upon anything for the resident as of now. Just an exposure and observation.
According to me, for the postgraduates who are sitting here, I think so the time has come that all these postgraduates should learn how to do trust.
Yes.
That is very important. That should be the message.
So message.
Machine is irrespective, that will come the second issue.
Yes.
But first they should not get, so they should start doing themselves.
Yes.
Most of the urology departments, like in AIIMS also, when I started in 2002, we have purchased a machine in the department because radiologists are very busy. They don't have time. So we started our own doing ultrasound. So my experience also goes like that. In one day we have not become that mature. So from the postgraduate level in the curriculum also, I think this should be included. That is my suggestion.
Yeah, absolutely fine, sir. The message is why this workshop for the urology residents today here is we should try to use this ultrasound as an office stethoscope. It is our stethoscope, urologist. You will not only biopsies, you just use it in your diagnosis. Now we have shown you how to do a biofeedback, how to make patient run a PFMT. You can see objective evidence are there. Stage your patient, pre-op, post-op, follow-up. It's a beautiful tool. Get used to it. And then again, if there are questions about PCPNDT Act, there can be some questions in the resident mind about PCPNDT Act. But I think it's very clear, the Act is very clear that it can be used by any registered medical practitioner, and there are guidelines for it, and you all follow that, and you can definitely. One thing I need to say, a center which is already having ultrasound practice residents are doing well, as our center residents do it. They have a system 24/7 access to this. I think that should be a part of your logbook. I will always suggest When you maintain your logbook in a procedure, mention all the your ultrasound procedures, and because it is countersigned by your faculty, the head of department, that makes the indication that okay, it is in your logbook. Second important point I would say, in our center, that state has a registration for PCP and EG.
Yes.
And they say every user needs to get it. It is an opportunity for the residents to get it registered when they are doing training. Forget about it, after 3 years, you will shift somewhere else. Right? But if you are registered by PCP and certificate, you are registered as easier to get transfer. So all these clinical issues can do. I think sir, we will shift to the next session.
Thank you.
Thank you so much.